Hello. First of all, thank you very much for your interest in the Simpler tool. This is a validated intervention tool to increase the quality of diabetes care. This training session consists of 4 modules, modules 1, 2, 3, and 4. It takes about 2 hours to complete all modules. So first, the training module outline is divided into module 1, which consists of pharmacist's role in diabetes management and the background of research. Module 2 will outline the 7 diabetes indicators and the benefits of using the Simpler tool. In module 3, you'll learn about how to get the information gathering process and also how to practice effective intervention using the Simpler tool. In module 4, you will be able to learn to write case notes using the Simpler tool. So a little bit about myself. I did my undergraduate in Liverpool John Moores University, which is in UK, and I took a break. I came back to work, and then after about 11 years, I did my master's in University Science Malaysia locally, and I obtained my master's in clinical pharmacy. And after about 3 years, I decided to about 4 years. After about 4 years, I decided to pursue my PhD, and I did that in Curtin University, Perth, in Western Australia. So I have extensive experience in diabetes management, whereby I was a GM Tech pharmacist since the year 2011, and I was also the preceptor as for the would-be pharmacists who are training to become DM Tech pharmacists. So Hospital Sultanah Aminah, where I worked, was a training center, and therefore I became the preceptor. After about 3 years working as a DM Tech pharmacist, I decided to pursue my PhD, and that's when I actually went to do my PhD from 2014 to 2017, and then later on I came back and still practice DM Tech up to this day. But in 2022, I was actually made the lead coordinator for DM Tech services for the state of Johor. So right now, here I am, working in Clinical Kesihatan Sultan Ismail. So previously, I worked in Guardian Pharmacy as a community pharmacist in UK for Boots Chemist, and then Guardian Pharmacy, and then I went on to be a pharmacy enforcement officer, and then I went on to be a clinical pharmacist in Hospital Wanita dan Kanak-Kanak Sabah. I actually spent about 8 years in Sabah, and then I became a hospital pharmacist, outpatient pharmacist in Hospital Sultan Aminah, whereby because I've got masters in clinical pharmacy, so I practice DM Tech pharmacy. And then I also have experience as being a research assistant in Curtin University in Perth, and also a residential assistant because I lived on campus, so I did what a residential assistant would do. And that's it. That is my working experience. So let's start with the module 1. So as outlined before, as I mentioned earlier, there were 7 key factors in diabetes management. So how did I get the 7 key factors? I actually went through the clinical practice guidelines from the America, from Australia, from Malaysia, from UK, and they pretty much talked about the same thing. There were 7 key factors of diabetes management that actually emerged from all these guidelines, and they are cholesterol management, blood pressure management, glucose management, and also about medication adherence, lifestyle, education, and also cardiovascular risk factors. So I've summarized this in the slide that you see before you. And actually, pretty much whatever that's in the guideline stemmed from these major, large landmark studies. That was the DCCT, the Diabetes Control and Complications Trial, which was carried out in the USA, and the UKPDS, which was conducted in the UK, and then the advanced trial, which was conducted in 20 countries, comprising of Asia, Australia, Europe, and North America, and also the veteran diabetes study, diabetes trial that was conducted in the USA, and also lastly the ECOT trial that was actually carried out in the USA as well as Canada. So what was incorporated in the CPG is pretty much stemmed from the key diabetes landmark studies, which actually talks about the glycemic, blood pressure, and cholesterol control, and then the targets individualized to each patient, reduction by 1%. So it's actually individualized to patient depending on their comorbidities. And what happened was that when they followed up the UKPDS trial, 10 years follow-up of UKPDS patient, they found that a 1% reduction of HbA1c can actually reduce the risk of having complications. So that was 21% reduction in diabetes death, 37% in microvascular complications, 43% in amputation, 14% risk reduction of getting myocardial infarction. So that's why it's so important to reduce HbA1c by at least 1%. But most of the randomized control trials and the diabetes intervention studies that were published, they don't always report the outcome of 7 factors, as I mentioned earlier. Despite showing a reduction of sometimes HbA1c of 0.6 to 1.9%, there is no mention of a structured tool that is able to produce a sustainable outcome once the patients have completed the trial. So most of these studies were compared with control group, which was seen less frequently. For example, once at the beginning and once at the end of the study. So there is a question whether the outcomes may be positive due to the regular contact with healthcare professionals, as shown in several studies. So some of the RCTs only focus on education, and they managed to reduce HbA1c. Some of them focused on education, medicine management, pharmaceutical care, and lifestyle counseling, HbA1c, as well as cholesterol levels, but not all the 7 factors. Some even focused on self-management, and that even purported to reduce HbA1c. So when I specifically looked at the pharmacy intervention studies, most of the pharmacists who were in this trial had a minimum of 3 years of practice. So I was wondering, and I was thinking, if the intervention that these pharmacists who are experienced sustainable. So for example, what if a pharmacist has limited experience in clinical practice? For example, new pharmacists who just graduated, will they produce the same outcome? So that's why I came up with this tool that incorporated all the 7 factors, and I summarized it into blood pressure, lifestyle, education, statin, which is for cholesterol, insulin, blood glucose, cardiovascular disease risk, and also medication management. So what I did was I took the first letter of each word or the second letter of each word, and then I just rearranged the words to form an acronym called the Simpler. So there we have it, the Simpler Diabetes Management. So I've been running the MTech Diabetes Clinic with fellow pharmacists for 3 years, from 2011 to 2013. And I did a retrospective study on all my patients that I've seen together with my team. And we plotted the graph and collected the data to see how much HbA1c was actually reduced. And we managed to get a figure. There was a whopping 1.33% reduction of HbA1c during the first visit compared to the most recent visit. And of course, I looked at all the other factors like medication adherence, knowledge, number of hypoglycemia, whether they were on ACE inhibitor or ARB, whether they were on statin, aspirin. But one thing that I didn't report was the number of patients hospitalized or suffered from cardiovascular symptoms, despite our efforts. So I found out that it was pretty hard to deliver pharmaceutical care, especially if a pharmacy is not trained and if the quality of life of patients improved. Despite having these challenges in the beginning, we managed to overcome it by being trained and experienced throughout the years. What I just want to say is that sometimes we don't have the luxury of gaining experience first and then delivering quality diabetes care. My contention is, why don't we just provide quality diabetes care from now, from the beginning? Because the prevalence of diabetes is increasing. In Malaysia, the latest is 18%. 1 in 5 person in Malaysia has diabetes. So we don't have the luxury of waiting. So isn't it time that we did something now rather than waiting to gain experience? So with that in mind, I decided to develop, assess, and evaluate the application of the simpler tool. And that was to support pharmacists by giving a structured and consistent diabetes care. And it should be applicable to primary as well as secondary healthcare settings, and be able to integrate into MTech diabetes. So in other words, not to replace MTech diabetes, but rather as a supplement to MTech diabetes. So with that in mind, I decided to pursue a PhD to come up to actually validate this tool, develop this tool, assess and evaluate this tool. So I decided to first design, validate and refine the simpler tool, measure pharmacists' application of diabetes guideline, and measure the clinical outcomes and the quality of life of this tool. So to validate the tool, I need a consensus of the tool and important issues that should be addressed from the main 7 factors, from endocrinologists, physicians, pharmacists from both countries. I used the Delphi technique through email. So round 1 would be showing them the 7 factors and the issues that need to be addressed and asking them if they have any other suggestions. So this was in phase 1 of the study. Round 2 would be collation of scores and categorization suggestions and construction of second questionnaire. Group consensus was then achieved when 60% or more respondents gave the same response on a particular question. So phase 2 was a qualitative structured interview on design on pharmacists who are ultimately going to use the tool, to refine the tool in terms of ease of use, intervention format, ease of remembering, and clarity of tool. This will be conducted in Malaysia and Australia. It was actually conducted in Malaysia and Australia so that the tool can be adapted to a different healthcare systems. Phase 3 was the randomized control trial, and I did it in 7 pharmacists, primary healthcare pharmacists or clinic kesihatan in Johor, Malaysia. There were 154 patients involved, and there were 14 pharmacists involved. It was a 6-month follow-up. So the Delphi process had to be approved first. So we got ethics approval from Curtin University, and the method followed the Delphi. So it was also used in previous similar studies. So that's why I was confident to use the Delphi method. So the recruitment of participants were by use of purposive sampling, the knowledge and experience in the care of diabetes patient. They were particularly selected. Some of them were my personal contacts, and some of them were actually experts, and they nominated other experts. So the experts comprised of academic, government, private, and public health sector pharmacists, and endocrinologists and diabetes nurses. And I recruited them from both Australia and Malaysia. So So it was actually conducted from September to December 2014. There were 12 participants, 7 from Malaysia and 5 from Australia. So you can see pharmacists were included, general practitioners were included, endocrinologists were included, as well as diabetes nurse. So there were 7 key factors in the simpler tool, 38 indicators, and they were based on recent diabetes guideline from both Malaysia and Australia. The consensus was achieved in 3 rounds. So 36 out of 38 indicators obtained consensus, and there were 5 indicators that did not obtain consensus for inclusion into the tool. So the final version had 32 indicators. So basically what happened is that I conducted it by using a questionnaire. So the questionnaire was part 1, and these were the indicators that should be included in the tool. And the indicators were based on clinical practice guidelines. So in other words, I was just asking the experts the order which it should be placed. So if you place it on number 1, then it's the most important indicator, followed by number 2, which is the most important, and number 3, which was the most important. So the order that the experts selected will then be reflected in the simpler tool handout. In questionnaire part 2, it was more on the handout of the design preference. So for example, what kind of handout would they like? Would they like a wheel, or would they just like a simple bookmark style? And what are the additional indicators that should be included in the handout? These additional indicators weren't in the clinical practice guideline as opposed to part 1. Part 1 indicators were all exclusively from the clinical practice guidelines. So in part 2, most of them were from randomized control trials, large randomized control trials, documented evidence. So this was put out there to get consensus. So consensus was achieved in round 3, and there were more than 60% of participants picked the same number. And in part 2, a score of 4 or 5 was chosen by the participants, and again, it should be more than 60%. Only these numbers and indicators chosen by majority were included in the simpler tool. So moving on to phase 2. So in phase 2, I actually developed the training process, I validated it, and then I actually trained pharmacists from both countries, from Malaysia and Australia, to use the tool. And then I did a qualitative interview with the participants on their perception of the training program and the simpler tool itself. Any suggestions from them for improvement were used to further refine the simpler tool. So in the phase 2 method, it was more like a qualitative study. So it was a 4-week, it was 4 weeks given to each pharmacist to go back to their daily practice and start using the tool, and then come back after 4 weeks to let me know how it went. So the pharmacists from Australia, I did a face-to-face interview, whereas because of logistics, I was actually staying in Australia at that time. So pharmacists from Malaysia, I actually did it through the telephone. So these were the actual models that you're actually seeing right now, module 1, 2, 3, and 4. So in phase 2, the results were very, very positive. This was some of the perceived benefits of the simpler tool. This were some of the opinions and comments from the participants. So they were all very, very positive comments. So I was pretty elated at this point. So I actually presented the results of phase 1 and phase 2 during the Australian Disease Management Association conference in Melbourne in 2016. And then I also did a poster presentation in Sydney, specifically on phase 2 results. And phase 3 is the randomized control trial, which ran for 6 months in 7 primary healthcare clinics. Patients were blinded, and it was 2 arms, and there were 14 pharmacists involved. So this was actually done in the state of Johor, comprising of all the districts a wide geographical area to give a more generalized and more accurate depiction of the demographic. So there were 14 pharmacists without formal diabetes training recruited. So in other words, they are not DMTech pharmacists. They had never been trained as a DMTech pharmacist. So these were the pharmacists that I picked. Majority of them, 71.4%, had less than 1 year of providing diabetes management service. So I trained all of them to have skills during pharmacy using the simpler training modules. So in the randomized control trial, I managed to get positive results after 6 months. HbA1c reduced to 1.59%, systolic blood pressure reduced, and the overall quality of life reduced, and all of them gave significant improvement. So again, the reduction of 1% HbA1c clearly showed benefit among these patients in our study. So significantly more patients in the intervention achieved guideline therapeutic targets. So these were some of the results. So they were all very significant. So some of the problems identified, I think there's no surprise. Non-adherence to medication was the majority of the problems, constituted the most problems, and then subtherapeutic dose, and also needs additional therapy. So the main causes of non-adherence was patients forget to take, and patients prefer not to take, and the subtherapeutic dose was related to insulin titration. The additional drug that was mentioned there was the need for insulin, the need for ACE inhibitor, the need for aspirin. So the findings of this study was similar to a study that involved multiple health clinics in Malaysia that was done back in 2015. The interventions to resolve non-adherence by pharmacists were pill reminder chart for patients, reinitiated drug therapy in patients, because there were some patients who refused to take the medications or stopped taking the medications for whatever reason. And so the pharmacist then reinstated the drug therapy in the patients, and therefore they continued to take it. So most of these recommendations were accepted by the prescribers, especially when pharmacists suggested to add additional medicine or change the dosage or change the drug product, for example, to a different brand, or discontinue drug therapy due to adverse drug reaction. So in terms of patient education, this trial actually focused on patient education as well, and the management of hypoglycemia particularly, and self-monitoring of blood glucose, also to reduce sodium intake and dietary advice using the plate model, management of stress and diabetes-related stress, as well as sleep hygiene, food care and simple exercises, and medication optimization during the fasting month for Muslims. So in terms of patient education, this study used Framingham risk calculator to educate the patients and to teach them that it's important for them to keep HbA1c at a reduced level. So the most important thing that was taught to patients that improved the medication adherence was knowledge and understanding of medications. So basically, what is the medication for, what the medications will do, when to take them, and what possible side effects that could be experienced. So I found that that was very, very useful in terms of educating the patients, and yes, there are several studies to support this. So this research inclusion criteria was patients aged more than 21 years on multiple medications, and HbA1c more than 8%, or even fasting blood glucose more than 7, or 2 hours postprandial glucose more than 8.5. So as such, the results of this randomized controlled trial could be generalized to patients with similar criterion, which is, of course, the majority of diabetes patients in Malaysia. So the conclusion is, pharmacists utilize a simple tool to consistently address all the 7 diabetes factors, And this led to significant improvements in glycemic, blood pressure, and quality of life outcomes. So pharmacists with limited clinical experience can be trained to use a simpler tool to deliver quality diabetes care. So I'm especially elated with the results and the findings of this study because pharmacists were not trained to train, the 2 weeks training for MTEC diabetes. They never underwent that. They were never involved in that. All the 5 days in clinical setup, they were never involved in that. And yet they managed to produce excellent results. And that shows the benefit of using the simpler tool. So the reason why the tool is developed specifically in Australia and Malaysia is to prove the flexibility and applicability of the tool in countries which differ in terms of culture, healthcare system, with the objective to prevent complications in diabetes patients. On the other hand, both countries have similar clinical practice guidelines on diabetes and established medication management service. So the findings of this study, the last randomized controlled trial study that I did, was presented as poster and oral presentations during the Diabetes Asia conference in Kuala Lumpur. That was back in 2017. And the best part is I managed to obtain the second prize for Best Oral Presenter. It was also presented as a poster presentation during the APSA Accept conference in Brisbane, Australia. The 2 wonderful ladies standing there, beautiful ladies, are my supervisors. 5 journal articles has been published pertaining to a simpler tool, which further signifies the importance and the significance of the study that was conducted. Phase 1 was published in Journal Diabetes Research. Phase 1 study was when I came up with the idea that 7 factors need to be considered, multiple factors, basically the 7 factors when delivering quality diabetes care. The validation of the simpler tool was published in Current Diabetes Reviews. The training process and the validation of the training modules was published in in Pharmacy Practice, which is a journal. The results of the randomized controlled trial in terms of the blood pressure, the clinical outcomes, the cholesterol and the blood glucose was published in the Journal of Diabetes, and the results of the quality of life as well as the pharmacy intervention that was conducted by pharmacists was published in the pharmaceutical. I guess what I'm trying to say is that this research is something that actually enabled me to contribute to make a difference in diabetes management, and I encourage all of you, if you have the opportunity and if you have the interest, to do research, and I think that is really beneficial. So we have come to the end of the slides. Thank you very much for your patience in listening to me presenting from slide 1 up to now. So if you have any questions, do not forget to post them in the Google Classroom, and I'll definitely get back to you as soon as possible. Thank you once again.